are going to discuss about menorrhagia. Menorrhagia means increased bleeding. Okay, menorrhagia means increased amount of bleeding in females. Okay, it can be seen in young and it can be seen elderly. So since our topic is today reproductive and premenopause women, we are talking about elder and young. Okay, if it is in younger, means increased amount of bleeding in case of young. Mostly it will be like due to anovulatory cycles. So we need to check whether they need contraception or not. If contraception is needed, then we should advise them OCP pills, progesterone only pills, Mirena. Okay, and then we need to follow up them whether they got treated or not treated. If they are got treated, then you need to continue it for 6 to 9 months, and you can then follow up them. If not, then you need to do minimally invasive surgery followed by hysterectomy. If minimally invasive surgery didn't work, means you can go for hysterectomy, but you should conserve ovaries here. Okay, you should not remove ovaries. And then if contraception is not needed, then you need to treat them symptomatically, like by giving ethamsulate, which is a like prostaglandin synthesis inhibitor, and NSAIDs like ethamsulate and tranexamic acid, which can decrease the bleeding. Okay, decreasing the blood loss. Okay, like that you can treat them symptomatically. If they are elderly, then you need to check whether there is any uterine pathology or not, like enlarged uterus is there or not. If enlarged uterus is there, then you need to go for directly surgery. Here no minimally invasive surgery because they are all elderly, so you can directly go for hysterectomy with oophorectomy also if they are above 50 years means. Okay, if there is no uterine pathology, then you need to treat medically. If not recovering, means if not getting treated, then you need to go for surgical treatment. Okay, then here in elderly there is no concept of minimally invasive surgery because chances of recurrence is there, so you need to do complete, like to the bottom you need to remove the uterus, then only it will be safe for them. Okay, now what is the etiology in case of AUB, in case of reproductive and premenopausal women? The etiology mostly will be anovulatory cycles or metropathia hemorrhagica. You all know what is anovulatory cycles. Here there will be painless menstruation because there is no ova is getting released. Okay, that you all know. Now what is metropathia hemorrhagica? It means there is a period of amenorrhea, like 6 to 9 months period of amenorrhea will be there. Thereafter menstruation will start, and again amenorrhea, again menstruation, like that. That is called metropathia hemorrhagica. It is mostly seen in elderly people. Okay, elderly people. Okay, now one thing that you need to remember is if they are older people, then you can go for directly for dilatation and curettage. If they are young, you cannot go directly to dilatation and curettage. You can use medically by symptomatic treatment. If it is not working, then you need to do endometrial biopsy instead of dilatation and curettage. You need to do endometrial biopsy. Okay, by either hysteroscopic guided, like that. Okay, or laparoscopic guided, but you are not supposed to do directly dilatation and curettage. Okay, now what is the pathology here? Why all it is occurring? Why all this is occurring? Okay, the main pathology in case of metropathia hemorrhagica is myohypoplasia that leading to large uterus. See, in case of elderly there will be large uterus if there is any pathology. Okay, and when you come to endometrium, here you saw about myometrium, now endometrium. In endometrium you will see many polyps with cystic glandular hyperplasia. See, these are cystic, means the secretions are not getting out, they are inside the glands itself, so the glands are getting cystic appearance and they are hyperplasia, and there is hyperplasia, like that. Okay, now endometrium also show absence of corpus luteum and corkscrew glands. Corkscrew glands will be seen in case of normally functioning endometrium. Since it is not normally functioning, so there will be no corkscrew glands and there will be absence of corpus luteum. Okay, now what are the investigations that you are going to do? You took history, you examined the patient. Okay, and you rolled out the pregnancy, everything. Now what are the investigations that you are going to do? We will start with the basic investigations like blood test in that CBC, then coagulation profile, like that you will do CDBT, that all will come here. Okay, now you need to know about structural abnormalities, so you will go for imaging modalities like ultrasonography, MRI, if needed hysteroscopy, like that. It is directly visualized under our eye. Okay, and you can also go for histopathological examination of the contents that you got during dilatation and curettage, hysteroscopic guided endometrial biopsy, or endometrial aspiration biopsy. Okay, these are all the investigations, like basic like blood investigations and imaging modalities and histopathological examination. Okay, now you did everything. Okay, and you all know what is the main clinical feature here. They will be having increased bleeding. Okay, and due to that you can also write constitutional symptoms of anemia, and due to that there will be loss of hair like that you can write, and pale tongue like that you can manage with the clinical features. Okay, I'm not going into that because you can write. And now we are directly jumping into the treatment. What is the treatment of AUB in case of reproductive and premenopausal women? Okay, premenopausal women. So here there is heavy bleeding. Okay, heavy menstrual bleeding. Okay, so if minimal, it is in minimal quantity means, then why to treat unnecessarily, and you are giving side effects to the patient? So don't treat them, just observe. So observation will be a good option if there is a minimal bleeding. Okay, if there is a minimal bleeding. If it is of severe type, then you go for medical management. Like here I given a mnemonic A, B, C, D, E, F, G, H. That is a mnemonic for the medical treatment. A means estrogen. B means it is sound similar, like in sound it is similar like PB. So progesterone. C for clomiphene citrate, and which is an anti-estrogen, and D for danazol, which is a anti-androgen. Okay, and E for ethamsulate, which is an NSAID, and F for antifibrinolytics. So you are making to decrease the blood loss, and G for GnRH analogs. Okay, GnRH analogs. Okay, these all will be used as a medical management. Okay, these all will have side effects. So if these are not working, or patient is complaining of many side effects and she is not able to tolerate these medical therapy, then you can go for Marina. Marina is an intrauterine device which is of hormonal. Okay, hormonal type of variety, means it is a third generation variety of IUCD. Here there will be no side effects, but sometimes irregular bleeding may happen, but it is better than medical management. Okay, so you can keep Marina. If due to this also patient is not able to, like, cooperating or not able to tolerate, and she is asking you to do something better, then you can go for minimally invasive surgery. Means in minimally invasive surgery, the only one and only option is ablation. We can do many types. There are first generation and second generation. First generation means these are somewhat old, like hysteroscopy, guided ablation of the endometrium, and transcervical resection of the endometrium, like that. Okay, and these are having many side effects and they are expensive, like that. Okay, when you come to second generation, they are very safe, very cheap, and equally efficacy with first generation, and they are easy to do. So you are mostly preferring second generation minimally invasive surgery, means second generation type of ablation, which include radiation induced or thermal endometrial ablation. Okay, and you can also use microwave ablation. Okay, and you can use tamponade effects like uterine tamponade, balloon therapy, like that. And you can also use bilateral uterine artery embolization, also bilateral uterine artery embolization. You can also do that. If still these are not working, means that is recurring, there is recurrence, then you can go for directly hysterectomy. Either you can go for transabdominal hysterectomy, or you can go for vaginal hysterectomy. You can go any one, but mostly vaginal hysterectomy is preferred over transabdominal hysterectomy, because there are many advantages with the vaginal hysterectomy, like decreased blood loss, decreased morbidity. Okay, decreased incidence of infections, surgically induced infections, and the procedure is very easy, and the patient can recover well. Recovery will be very well. Okay, and anesthesia complication will also be very less. So there are many advantages like that because of vaginal hysterectomy over transabdominal hysterectomy. So mostly prefer vaginal hysterectomy. Okay, now there are some terms like irregular ripening, irregular shedding. Okay, I will say very simple words. What are those means? See, rip. Ripening means rip is there, right? So rip means the corpus luteum has got deficiency of the corpus luteum. Okay, due to that there will be spotting before menstruation itself. So before menstruation itself, spotting is happening. That is called irregular ripening. Okay. Now shedding. Irregular shedding means you can remember like Shashwat corpus luteum. Shedding you have in shedding mein Shashwat corpus luteum will be there. So there will be corpus luteum which is persistently active. So the corpus luteum is existing more than the period that it should be. So there will be prolonged menses. So once the menstruation started, means it will last for 1 month, like that. Okay, that is called irregular shedding. These two pathologies, irregular ripening and irregular shedding, is mainly occurring due to ovulatory dysfunction. Okay, ovulatory dysfunction, these two are occurring. Okay, this irregular shedding is also known as Halban disease. Okay, Halban disease. Okay, and that's it for today. I hope you understood that's something that I'm saying. Okay, I know I'm poor at teaching, so I'm trying to improve, because we should always try to pass whatever the content that we learned. Okay, we should pass to next generation. Okay, next generation means I'm at still little age, so I'm trying from now only, and I hope you liked it. But before going to end this video, just will revise once. So overview, we need to know that today topic is menorrhagia, so increased amount of bleeding, that is in young or elder. If it is in young, we need to know about contraception. If they need contraception, then you need to go by OCP pills, POP and Marina. If getting treated, then continue. If not, then go for surgical options. If there is no need of contraception, then you need to go for NSAIDs and tranexamic acid, which will be symptomatic treatment. And if it is of elderly, then you need to check for whether uterine pathology is there or not. If there is pathology, go for surgery. If no pathology, then go for medical treatment, then surgical treatment. Okay, and no minimally invasive surgery in case of elderly people because of recurrence. Okay, now etiology. What will be the etiology? Etiology will be anovulatory cycles or metropathia hemorrhagica. Mostly in reproductive people, anovulatory cycles will be there. In metropathia hemorrhagica, it is seen in elderly. Okay, and pathology, when coming to the pathogenesis, like myohyperplasia, endometrial hyperplasia, like that you can remember hyperplasia of the cystic glandulars, and here there will be myometrial hyperplasia. Okay, now then coming to investigations, only 3 investigations: blood investigations, structural investigations, and histopathological examination. Okay, I hope you remember this investigation part. Now coming to treatment. What is the treatment? ABCDFGH. Okay, see, you need to treat only if there is heavy menstruation bleeding. If there is minimal, no need of treatment and matter. Okay, ABCDFGH. So that is a medical treatment. A for estrogen, progesterone, clomiphene citrate, and danazole, ethamsulate, antifibrinolytics, and GnRH therapy. If the patient complains of side effects and the treatment is not at all sufficient, then you can go for Mirena introduction. Mirena has no side effects, and only very sometimes it having irregular bleeding. Okay, and if patient is not able to tolerate that, also you can go for minimally invasive surgery, which has 2 generations, first generation and second generation. You can remember what are the things that are present here. Okay, and why second generation have more advantages. If still there is a recurrence, then you can go for a hysterectomy, which includes the abdominal hysterectomy and vaginal hysterectomy. We should prefer vaginal hysterectomy over the transabdominal. Okay, now there are symptoms like irregular ripening and irregular shedding. Ripening means rip deficiency of the corpus luteum. Corpus luteum has gone. Shedding means shashwat corpus luteum. So there will be persistent corpus luteum. Okay, I hope you understood the lecture. Thank you very well, and if you liked the content, then please do subscribe our channel and like it, and do share with your friends. Even if you are not able to do this, just comment that this video helped me, so that it will be a big motivation for me to do further more videos. And thank you very much for watching my lecture, and all the very best for your future preparation and exams. You are the best, you will do the best. Just have faith on yourself. Krishna is always with you, he will help you. Just have faith on yourself, and always remember that God is there ahead of you, and he will protect you at all the times. And thereby signing off, all the very best. Okay.